يلا يا
Our subject today about radiological anatomy of the sigmoid rectum and anal canal. Sigmoid colon. The sigmoid colon is variable in length, 12 to 75 cm, average 40 cm. It is covered by double layer of peritoneum attached to the posterior and left lateral pelvic wall. It has the same circulation pattern as the rest of the colon in young people. In the older people, it may appear featureless, the redundant sigmoid lie on the other pelvic structure. Relation of the colon and
على
sigmoid.
كيفك على كيفك
تمام.
لا تستعجليني.
Relation of the sigmoid colon. Anteriorly in male, the bladder; in the female, bladder and uterus; superiorly lobe of small intestine; posteriorly the left internal iliac artery and vein; left ureter piriformis muscle; sacrum and sacral plexus. Laterally in male, pelvic side wall ductus deferens; in the female, pelvic side wall and ovary. The blood supply, arterial supply, is from the inferior mesenteric artery via the sigmoidal artery. Venous drainage is to the portal system via the inferior mesenteric vein. Lymphatic drainage via the blood supply to the pre-aortic node around the origin of the inferior mesenteric artery. The rectum is about 12 cm in long. It covers the interior to S3 and in the anal canal, which is 2 to 3 cm in front of the tip of the coccyx. It forms the anterior posterior curve in the hollow of the sacrum. The rectum has no circulation or mesentery. Its upper third is covered by peritoneum on its front and side. Its middle third has peritoneum on its anterior surface only, and the lower third has no peritoneum. The lower part of the rectum is dilated into the rectum ampulla. In the resting state, the mucosa of the rectum has 3 to 4 longitudinal mucosal folds known as the column of Morgagni. These measure 3 mm in width. The tinea coli fuse in the rectum. Some longitudinal shortening of the rectum occur, giving the rectum slight S shape. This is created from above to downward 3 lateral mucosal folds, which is left, right, and left, known as valve of Houston, and usually less than 5 mm in thickness. This is the sigmoid rectum, rectosigmoidal junction, and this is the valve from superior to the inferior, left, right, and left. Relation of the rectum. Posteriorly are the sacrum and the coccyx. Anteriorly, the lobe of a small bowel and the sigmoid colon, like in the peritoneum cul-de-sac between the upper 2/3 of the rectum and the bladder in the male, and the bladder and uterus in the female. The lower third is related to the vagina in the female and to the seminal vesicle, prostate, and bladder base in the male. Rectum surrounded by perirectal fat, fascia known as perirectal fascia surrounded the perirectal fat, and lateral to the perirectal fascia is the pararectal fat. The perirectal fascia separated the seminal vesicle and the prostate from the rectal anteriorly. Anal canal, which is 2 to 3 cm, directed posteriorly almost at the right angle to the rectum. It is narrow muscular canal. It has an internal involuntary muscle and the outer external voluntary muscle, blend with the levator ani muscle. The internal smooth involuntary sphincter occupy upper 2/3 of the anal canal, and the external striated voluntary sphincter occupy the lower 2/3. This sphincter overlap in the middle third with the internal deep to the external. The junction of the rectum and anal canal is at the pelvic floor, where the puborectal sling encircle it, causing its anterior angulation. Relation of the anal canal. Anteriorly, the perineal body separated the anus from the vagina in the female and pulp of the urethra in the male. Posteriorly, anococcygeal body is between it and the coccyx. Laterally is the ischiorectal fossa, which is occupied by the fat. Anal canal lined by the mucous membrane in its upper 2/3 and the skin in the lower third. The mucosa of the anal canal has several vertical folds. Radiological pair, the mucocutaneous junction known as the dentate line or Haliton white line. This defines the division between arterial supply and the venous and lymphatic drainage. Blood supply of the rectum and anal canal from the superior rectal artery, middle and inferior. The superior rectal artery, which is terminal branch of the inferior mesenteric artery, supply about 2/3 of the rectum. The middle branch from the internal iliac supply the mid and the lower rectum, and the inferior rectal artery branch of the internal pudendal supply the mid and the lower rectum. Venous drainage, the vein corresponding to their named artery from the rectal venous plexus, consisting of an internal part within the submucosa and an external part outside the mucosal layer, the muscle layer. This represents the side portosystemic anastomosis. Superior rectal vein drain to the inferior mesenteric vein, middle in the internal iliac vein, and inferior rectal vein drain into the internal iliac vein via the internal pudendal vein. Radiology of the sigmoid and rectum, plain film, barium, enema, CT, colonograph, MRI, and dynamic study. The first one, the plain film, the sigmoid colon and the rectum may be identified on the plain radiograph outlined by the air, feces, or butt. The sigmoid colon has characteristic S-shaped curve as it joins the descending colon to the rectum, which is lie anterior to the sacrum. This is case X-ray of the abdomen supine view show hugely dilated loop arising from the pelvis with the coffee bean sign, a case of the sigmoid colon on the X-ray and on the coronal CT scan. This is the sigmoid volvulus. Barium, the second one, barium enema, the best detail attained by the double contrast. On the lateral view, the post-rectal space is measured between the posterior wall of the rectum and the anterior part of the sacrum at the level of S3. This measurement should not exceed 1 cm. The posterior impression of pubococcygeal fiber of the levator ani may be identified at the lower limit of the rectum. This is the sigmoid rectum, posterior wall of the rectum, and anterior part of the sacrum should not exceed 1 cm. Method double contrast, which is the method of choice to demonstrate mucosal pattern, and single contrast uses for localization of an obstructed colonic lesion using water-soluble contrast. As surgery or stenting may be required shortly after the procedure in children, which is not necessary to demonstrate mucosal pattern, and in the case of reduction of intussusception. The contrast, the low contrast, 150% of 500 mol of barium. Single contrast, the colon is filled with barium, which is outlined the intestine and reveal large abnormality. Double contrast or air contrast study, the colon first filled with barium, then the barium drained out, leaving only thin layer of barium on the wall of the colon. The colon then filled with air. This will provide detailed view for inner surface of colon, making easier to see neurons such as structure, diverticulum, and inflammation. Indication for benign tumors such as polyp, colorectal carcinoma, ulcerative colitis, and Hershey spring disease in children. Contraindication, there is absolute and relative contraindication. Absolute contraindication, toxic megacolon, pseudomembranous colitis, and recent biopsy. Rigid endoscope within the previous 5 days and flexible endoscope within the previous 24 hours. Relative contraindication, incomplete bowel preparation, consider if the patient can have, and recent barium meal, advised to wait 7 to 10 days, and patient frailty. Contrast media, the contrast, the polypar, 150% of 500 mol or more is required in double contrast using on-air equipment, disposable enema tube and pump. This is the set of barium enema. Patient preparation, there are many regimes. First one, 3 days prior to the examination, lower fluid diet. On the day of the examination, fluid only by Colax, which is laxative, consider admitting frail, elderly, and this with social problem. On the day of examination, it advised to place diabetic first in the list. This is a view of the barium enema, part of the bowel, the rectum, and the pre-sacral space view in the left lateral and prone position. Rectosigmoidal, sigmoid colon on the right anterior oblique, splenic flexure on the left anterior oblique, hepatic flexure on the right anterior oblique, entire colon, and the cecum seen on the supine view. This is of entire colon. See the sigmoid ascending the same transverse colon. Magnified view of sigmoid colon demonstrate the mid-sigmoid sessile polyp in face. This is case of Hershey Shivering disease. Barium enema showed reduced caliber and length of the large bowel with no clear transition zone. This is case of total colonic ganglionosis. This is also a case of Hershey Shivering disease, abrupt transition zone at the rectosigmoid junction, inversion of the rectosigmoidal index. This is case of colorectal carcinoma, which is the sign of apple core lesion. Ulcerative colitis lead by colon, tubular ahaustraf featureless colon. Third one, CT scan visualization of the rectum may be improved by the administration of diluted rectal air, contrast or air. This is the bladder, prostate in the male, and this is posterior is the rectum. Bladder, rectum in between cervix in the female. Transverse CT scan image of the pelvis in 85 years old woman with the large bowel obstruction caused by the distal fecal impaction. CT contrast using lung window show dilated colon with large mass impacted stool in the rectum. This is axial CT scan with contrast, show sigmoid with diverticulum, show extraluminal air. CT colonograph, this technique allows examination of the mucosa for polyp through the number of viewing technique, including surface rendered image, in which the interface between the mucosa and the air in the lumen is electronically rendered into the surface image of the lumen. This is CT colonograph of large sigmoid polyp with the homogeneous attenuation. MRI is used image in the of the rectum and evaluate of the mesorectal fascia and the rectal tumor. This is a bladder and this is the rectum, mesorectal fat surrounded by the mesorectal fascia. This is the sagittal view of the MR. This is the bladder, rectum, anus, and this is male. This is the prostate and symphysis pubis. Dynamic image. The rectum can be evaluated dynamically during the training or evacuation with the dynamic MRI or barium difficography. During defecation, the rectum and anus descend with the pelvic floor and acute anorectal angle increase training out as the contrast material is evacuated. During contraction of the pelvis, the rectum and anus ascend, the anorectal angle narrow, and the posterior impression is seen at the lower end of the rectum owing to the action of the puborectalis. This is the rectum and anus, and this is the anorectal angle, which is increased during straining and defecation.
اكو احد عنده سؤال قبل ما نبدي الكويز؟ ماكو. اذا نروح على سؤدد.
نعم أستاذ. letter A. This is the cecum.
اشري لهم بابا علي. هذا السيكم حتى اللي هاي ما منتبه. فرح زهير بي.
نعم أستاذ. ascending colon البي.
ascending. سي مرتضى.
نعم أستاذ. سي hepatic flexure.
hepatic. اوكي. احمد محمد جاسم دي.
نعم أستاذ. transverse colon.
transverse. اميد اي.
نعم أستاذ. هذا splenic flexure.
سبلينيك. ايمان حميد الاف.
نعم أستاذ. الأف descending colon.
descending colon مو descending. اي. اميد.
نعم أستاذ.
جي.
This is the sigmoid colon.
sigmoid colon هو اللي موضوعنا. تبين اتش.
نعم أستاذ. ريكتم.
هذا الركتم. وزينب هاتف.
نعم أستاذ. الآي anal canal.
لا هو مشر على الانر كانال لو على البالون؟
على الكاثيتر هذا اللي
على الكاثيتر مو صحيح؟
نعم.
اوكي. يلا أستاذ محمد.
نعم. هدى.
نعم أستاذ. sacral flexure رقم 1.
نعم. ياسمين 2. ياسمين فلاح. مروان 5.
أستاذ أنا رحت فليكشر.
رقم 2 أنا ركتر جانب أو فليكشر. زين. محمد الخضير 3.
نعم أستاذ. 3 أستاذ anal canal.
anal canal. محمد حسن 4. وين هي 4؟ هاي مؤشرتكم عليها 4. محمد حسن. شيماء مجيد رقم 4.
نعم أستاذ، هذا الساكرم.
ساكرم. زين. سماء عطية رقم 5.
نعم أستاذ. urinary bladder.
urinary bladder. زينة عبد الجبار 6. زينة موجودة؟ رغد سعدون.
نعم أستاذ. anal canal.
6.
رقم 6 prostate.
زين. رقم 6 بروستيت. آخر وحدة رقم 7 حسين عبد الكريم.
نعم أستاذ. هاي السنفذ بس.
كل زين. وبعد 8 لو خلصنا.
لا هاي خلص.